together now for 6 years, and everything is sort of meant to be. There's a lot of the slides that I'm showing you are exactly the same slides that Scott has shown you, which is great, actually. So I'm going to show you how I came to computational pathology. And I'm going to talk about two different topics. One is going to be, of course, our work on oral squamous cell carcinoma, and the other is going to be work that we're doing now on thyroid cancer. So, again, what's the problem? The problem is I don't know how to advance the slides. Oh, there you go. Okay, so we'll be talking about the quantitative risk model for oral cavity cancer, and then developing a tall cell pipeline for papillary thyroid carcinoma. And I'll explain what the problems are. The other arrow. Aha. Okay, so what's the high impact question? Well, as Scott has told you, we're focusing on patients who are stage 1, stage 2. So in the US, it's called AJCC, American Joint Cancer Committee staging system. We stage cancers according to the tumor size and the lymph node status. So a stage 1 or a stage 2 tumors in the oral cavity are small or perhaps a little bit larger, but they have not yet metastasized to cervical lymph nodes. Now, oral cavity is something that's very important to India. Bombay has the largest incidence of oral cavity cancer in the world. So this is a question that really plays home. So if a patient is treated with just the minimal type of treatment, only surgery, but then develops a local regional recurrence, it's a pretty debilitating type of therapy that they have to go through afterwards. Now, if you treated everybody, even low-stage patients, with very aggressive therapy, you're over-treating many patients. And the therapies themselves are not easy to go through. So there are features that are called aggressive pathology features, or APF. And different people use different features. They've been reported in the literature. But how they're used, how they're recognized, has not yet achieved consensus. Now, the risk model was something that I had originally reported in 2005, and then validated it in 2010, and then again in 2013. But it hasn't gained traction due to transportability. It's not something that you could just read in a book and say, this is how you do it. I actually teach it to fellows. I teach it to students who come to learn with me, but it really is a one-on-one thing. It's like surgery, like pathology. You wouldn't read about a surgery and then go out and do it. You wouldn't read about how to make a diagnosis and then go out to do it. You need a human mentor. So while this has been around for a while, it hasn't gained the type of traction that we'd like it to have gained. Now, when patients are recognized as being high risk, low stage high risk, they receive what's called post-operative radiotherapy. And so in lots of different hospitals, different tumor groups will use different features to recommend post-operative radiotherapy. But shockingly, there's not a consensus in terms of does post-operative radiotherapy really work on low stage patients. So there are a number of problems in here. And I just want to show you, these are just some of the reported features. You can't see this all, you're not meant to see this all, but for instance up here, this is tumor pattern of invasion, immune response, perineural invasion. So these are examples of different APFs, adverse pathology features, and then these are the actual study groups, and these are the findings. So as Scott mentioned, the risk model is a validated predictor of outcome. And many people have heard of Gleason staging, Gleason scoring. It's much akin to that. So you look at a number of different features, and you come up with a number of different variables that can explain high risk. So it's not just one face, but many different combinations can explain high risk. Now, a lot of this came from prior work in the literature. And what I did is I just kind of changed it around just a bit. And so what I just grouped together as non-aggressive are traditionally defined as patterns 1 through 2 and 3. And then pattern 4, which are small islands, that was sort of the end of the classification. But it became very obvious to me. So I always wanted to be a painter. And I would see tumors that look like this. You take a paintbrush and you flick paint, and it's like that tumor is growing in that way. But that's not specifically being recognized. And that's basically where I just came out with an extension of pattern of invasion. I said, well, let's just make this definition here. Let's make a box, something that we can remember. I said, okay, here's the box, here's the bin, 1 millimeter distance. Now, this is what pathologists do. We make sort of intuitive bins or categories, and we say, let's test this category, let's test that category. But we don't query across all different kinds of categories. And so as I was coming up with this, it was in a parallel process which was being unsolved. I thought, well, can't we look at all categories? So this is just an example of pattern 5, as Scott has shown you. Here's a small tumor, and you can't see here, but there's very little cords of the tumor invading, and then there's kind of a skip area here, and here's another sort of area of scatter, tumor scatter. So this was from the 2013 article showing you that pattern 5 itself, or the high-risk category with the combination features together, were both significantly predictive of outcome when adjusted for confounders. And this is for local regional occurrence, and this is for death-specific survival, disease-specific survival. Maybe I didn't want to do that. Yes. Okay. And these are area under the curves. And here I'm showing you with respect to local regional recurrence. Pattern 5 has a positive predictive value of about 42%. So it means if you have a small stage 1, stage 2 tumor, but it has this kind of scatter, you have a 42% likelihood of developing local regional recurrence. Well, you couldn't really market a test that gave you a positive predictive value of 42%. You'd be looking for something that had a better positive predictive value. Now, in the latest AJCC, what I ended up doing is migrating away from the whole risk model to just having people recognize pattern 5. Why is that? Because I wanted it to gain traction, to be adapted, and so it's easier to ask people, well, recognize this one thing. Is it this or not this? So pathologists will stage, when they write their reports, they have what's called College of American Pathology synoptic reporting. And so in the synoptic reporting, they're asked to recognize, is it pattern 5 or not pattern 5, as a way to promote adaptation of this model. Now, Scott spoke about occult cervical metastasis. I'm just going to show you something, and then we're going to go to the same data. So what's the thing with occult? Well, when you have metastatic disease in the neck, you can have a big lymph node, or the lymph nodes can appear normal. So if you, a doc will palpate the neck, will take radiographs, and so everything looks normal, but there are tiny, tiny metastases already there. So we were focusing on that because that in and of itself is a sign of aggressiveness. So I want to ask the question, can pattern 5 predict occult cervical metastases? And the short answer is yes, it can. Only for stage 1 cancers, which are defined as a very limited depth of invasion. And so here you have the p-value. Now, when you've gone from stage 1 to stage 2, you've lost that ability to predict occult metastases. So, as I said, when I was coming up with this risk model, there was this other parallel process which was unsatisfied in my head. And I was asking myself, can I go from this, which is, again, you can't see it very well, but this is all tumor, this is an ultrabed, and in here, there are little tiny strands of tumor. Well, can you convert this into this? And can you take this and make math out of it? So when I first met Scott, I'm like, well, can you can you make math out of this? And he's like, yeah, you can make math out of this. Okay. This is just another example. Here is all of this pink is tumor. All of this blue here is lymphocytes. This is muscle. Well, we can get from here to there. Can you make math out of this? And so that's where we came up with this idea of trying to perfect the risk model, starting with something that we know, pattern of invasion. And as Scott said, we did a lot of annotation. So these are the H&E sections, which don't show up very well. These are the annotations, which really are the representations of what we're chasing. So for instance, here's a main tumor, and all the way out here are some of the satellites. And Scott showed you the exact same images, okay? So, here we looked at different ways of doing Matlab. By we, I mean Scott. Here's Scott looking at different ways of doing image analysis. This is looking at the area that encompasses all of the satellites. Here we have Delaunay triangulations. And now the wave feature actually is like a representation of how tumors grow, because when you look at tumors in tissue, they sort of grow like stepping stones. They grow in this kind of wave. And again, this is just a pattern 5 tumor, so there's more dispersion out here. Again, looking at another way of Delaunay triangulations, looking at this wave pattern. And so, same data. Here's a scatter graph, and these are patients. The orange are patients who have undergone progression, and the blue, patients who have not undergone progression. So it's a way of looking at this and saying, something's there. All of the features that were extracted and used were based on distances between the main tumor and the tumor satellites. So it's not a surprise, but it's validating that we're on the right path. And so here we are comparing, it's really a small number of patients, 43 patients, which is kind of like nothing, unfortunately. I have population data here of almost 300 patients, and I'm looking at the performance value of pattern 5 and comparing that to this small group of 43 patients, looking at the performance value of pattern 5 just in this group and of the computational pipeline. So what you can see here is the accuracy of predicting local regional occurrence in this big population set. That's 71%. Okay, it works, right? Well, the accuracy is better here of the pipeline than of pattern 5. So, I knew that we could extend and perfect the model using this approach. And this is saying, yes, we can. Now, again, here we are looking at occult metastases. So I showed you that pattern 5 can predict. And again, occult metastases means the lymph node metastases are so small that you can't see them. You can only see them with a microscope. And here we have no occult metastases in orange. Sorry, occult metastases in orange, and blue here clumping, the orange here clumping. So the problem with 43 patients are they're different stages, different T stages. They're different N stages because some have occult metastases and some are N0. And so you'd want to be able to do regression analysis. And so you need hundreds. At least you need about 200 patients or so to really have robust data that you could analyze and then basically, look for confounders. So from here we get the idea, let's make these machine-generated tumor maps rather than spend all this time doing annotations. And so I won't go over this. Scott's gone over. This is filter classifications, and then deep learning, looking at multiple tissue classes. And what we've realized is that the tumor classification is probably more accurate when you can teach a pipeline to say it's not tumor because it's A, B, or C, rather than yes, no, tumor, no tumor. So it's tumor or A, B, C, D, E. So you're recognizing many different flavors of non-tumor. And Scott spoke to you about the random learning and versus the active learning. And so here's our version 2. So this is the next version beyond the strap, the bootstrap classifier. So actually, the green here is the color of blood. So the keratin was being misclassified as blood here. And here we see the tumor with these keratin pearls. So it's, to me, the first time I saw this, I thought, dang, this is like magic, right? But then you see, okay, you see what's being done incorrectly, and then you start correcting. Here's version 2, and this is when we were just showing stroma as stroma, and then we realized, well, stroma can be lots of different things, so we started perfecting that more. And here, what we see is the blue out here is supposed to be tumor, but it's really muscle, because when we look out here, there's no tumor. So we went back in here and started classifying the stroma as different kinds of tissue types. So this green here is all muscle. Here's version 3, which is the current classifier. And again, it's hard for you to see the tumor in here, but it's actually doing a pretty good job. So stroma is red, blue is tumor, green here is, I think, blood. Now here's some crazy results. And so it looks like the actual color on H&E is a strong determinant for how classes are assigned. So for instance, keratin is kind of pink-red. Tumor, if it's keratinizing, can be very pink, or if it's not keratinizing, can be very blue. So here we have, this is a nerve, and the nerve is encircled by tumor, but the classifier just picked up the whole thing and said, oh, this is all tumor. So no, it's not tumor. And the classifier is also, as Scott was saying, was very aggressive in recognizing things that are tumor. So for instance, here's a vessel, which has a kind of pink wall, and the vessel here is being recognized as tumor. So it's telling me that color is playing a very important part in what's being assigned. So then we go back in. This is the machine map, and this is our re-annotation. And so we introduce, okay, fine, this color is now nerve. So we go back and refine all of the annotations according to how the machine is misclassifying. And so this is so how we do it. These are the dice coefficients. And so here we are with random learning and with active learning. So bigger is better. So tumor recognition with active learning in the same version is 0.56, whereas with random it's 0.27. So basically we just continue to refine the classifier, and the goal will be to run a large set of cancers to be mapped by the classifier, and then to develop the pipeline based on the tumor maps. Now we're going to move on to a new question. Anybody have questions about this? Okay, so thyroid cancer is actually very common worldwide. And the most common thyroid cancer is papillary thyroid carcinoma. So let's look at what the issue is. In the US, the incidence is about 15 per 100,000, and that's basically kind of tapered off. So in prior articles, one would say, well, the incidence is increasing because we're doing more image modality. Well, now, over time, it seems to have really plateaued, so this may be the real current incidence in the US. And we classify thyroid cancers as well-differentiated or other. So this is well-differentiated thyroid cancer. And a patient who has, well, we're back to risk again. It's just a different paradigm, but it's the same concept. So if a patient has a low-risk tumor in the thyroid, they just get half of the thyroid removed. If they have a high-risk tumor, well, you're going to know that right away. You're going to know that preoperatively or intraoperatively. So they get their whole thyroid removed and aggressive therapy. So a patient who is found to have intermediate risk, if they've only had one part of the thyroid removed, they have to go back, the surgeon has to go back and take out the other side, which they tell me they don't like to do. And then they have to be tested with radioactive iodine to see if there's any uptake, which means maybe there's some cancer cells left around. And so if cancer cells are found, then they're treated with a larger dose that ablates them, that kills them. But this treatment with radioactive iodine, again, is not such an easy thing. So it would be nice to have a better idea of who goes into this intermediate class, who gets appropriate surgery, and who gets appropriately queried with radioactive iodine. Now, the AJCC staging, as I mentioned before, that's really risk of disease-specific mortality. Thyroid cancer, most patients live with thyroid cancer. So if you look at AJCC staging, it doesn't really help you. It's not informative. So as a response to that, the American Thyroid Association came up with risk of recurrence stratification schema. And I'm going to show you the current one that we're using, which was proposed in 2015. And so they use different combinations of features to classify low, intermediate, or high risk. Aggressive histology, which we'll talk about, is a buzzword for tall cell variant, and we'll talk about that. So, it's not written in stone. There's no grids that tell you, blah, 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 blah. But it shows you a sort of progression of risk. So, if you have a small tumor, it's less than 4 centimeters, or let's see, if you have one positive lymph node with no extranodal extension, these are examples of low-risk tumors. So it's different particular features that can classify you into a risk category. And so here there's kind of one image of low risk, but in fact there's a lot of different components to it. So something that hasn't left the thyroid yet, with 5 or fewer lymph node metastases. So what's an intermediate risk tumor? Well, it's a tumor that could have aggressive histology, or could be outside the thyroid but just a little bit, or could have vascular invasion, or could have more than 5 lymph nodes involved. So it's different features. Okay, and this is where I live, in that aggressive histology place. Now, the concept of tall cells has been around a long time. And so if you look in the literature, this is from 94 to 2000 to 2017. These are different studies showing you what the definition is of tall cell variant, which is was 50% or more of cells which are at least twice as tall as they are wide. And I'll show you pictures so you'll understand. The current definition actually changed, but let's say they have features. Let's say it's 10 to 40%, 10 to 49% tall cells, but not 50%. Well, it still has an impact on outcome. So there's lots of different publications which have shown that there's something there with it. But here's the ugly truth. It's a guesstimate. We look at slides and we estimate what the tall cell component is. So if you have a little tumor and it's one slide and I say it's 50% tall cells, okay, it's pretty easy. Well, what if I have 5 slides? And what if the size of the tumor is different from one slide to the next? And what if the amount of tall cells is different in one slide to the next? And I've got to assess it over a very variable landscape. It makes your head spin a little bit, right? So, and now, of course, what's the definition of tall cell this year, right? So I showed you articles, where the definition was 50% or more, but the current WHO classification is 30%, okay? So definition confusion is, among pathologists, is a known thing. What's the inter-observer concordance? What's the intra-observer concordance? And here's another scary question. What's the ground truth? When you go in there and you look at at a tumor, how many tall cells are there really? So the questions don't end. So now you understand why tall cell variant of PTC was begging for a quantitative approach. So what we realized is there's a protein called beta-catenin, which is a membranous protein. And we thought it would be pretty easy to just, let's start with this approach. We stain these tumors. We have the cells, a part of the cells outlined. Maybe we can use this as a way to start querying cell geometry. So what we see here is this is a small immunohistochemistry. The blue is nucleus. The brown are the lateral margins of these tall cells. Are they more than twice as tall as they are wide? Sure, but look over a lot of slides. It looks easy now, right? Now, so here was our goal. We thought it was pretty simple. Detect PTC, detect the tall cells, get a denominator, and just do math. Well, it's not so simple. So, for instance, this is a deconvoluted image, when you look at the white, which is the cell membranes, they're not always, exact lines. They're not always complete. So this is an example of Matlab programming that Scott did. And so here we have segmentation where the red are just nuclei, not specific for anything, but the red are nuclei here for PTC, here's for who knows what. Okay, the green is the counterstained immunohistochemistry for beta-catenin. So this is an area of tall cells. And hold on. Okay. So once you've got the cells and once you've got the membranes, well, how do you calculate the tall? And so we were going back and forth for a while on this. One of the things that Scott was using was the ray function in Matlab, where you start off with a nucleus, the center of the nucleus, you send out rays, and you see where the rays are stopped, truncated by the membranes. And so here's an example of that. We have the ray function. So all of the green here are cells that were detected, rays were sent out, the rays were stopped with the membranes, and all the red is mush, so the red goes away. And here, after removing the red, the non-bounded, we have all the green, which are the cells. Now the brown, which you see here, that's the actual immunohistochemistry. So that's showing us the cells that are being detected as compared to the cells that are actually there. So it's not bad, right? So this is now higher power, and this is the output. So the output, the green, are the tall cells, and the red, and some of these are really crazy red, right, are cells which are not tall. So when you look at this, it makes you a little kind of nervous because, some of these look like real cells, but some of these look like kind of not like real cells, even though they're not tall. And now if we overlay the pipeline, you see a lot of stuff is not being detected. So for instance, here's a beta-catenin staining. This is a tall cell. And here's the output on Matlab, and you see the ratio here is 10%. So it tells us, well, in this area, there are 10% of the cells here are tall cells. And we can see, obviously, it's more than 10%. So, back to the drawing board. So spent many weeks trying to tweak the Matlab pipeline to increase cell detection. And then, so this is very beautiful mosaic. The mosaic doesn't mean anything, just means the cells are being detected. So after some tweaking, here's an example of sort of the next iteration, where if you go back and forth, this was the first iteration, and this is the next iteration. We definitely have more cells that are detected and more tall cells that are detected. But still a lot of these crazy shaped cells, which in essence are like, multiple cells kind of mushed together, et cetera, et cetera. So we can increase the sensitivity of cell detection, but what about detecting the tallness? Well, it's not so simple to complete the box in order to calculate the geometry. And here you can see some of the reasons why. So you have in the immunohistochemistry, you have incomplete cell membranes, and then of course all the nuclei get merged together as one big blobby nucleus. So this is going to impact on what you're doing. So Scott was looking at other ways, other functions to start calculating cell geometry. And this is one of them, object growing. So again, starting with the nuclear centroid, you're growing a shape of an object until it stops with the immunohistochemical cell boundaries. But if you look at it high power, so for instance, here's a tall cell. Here's the contours that I'm tracing out with my finger, right? And so the object growing stops way before the contours of the cell, okay? Here we have another example. So here's the object, but here's the contours of the cell. So if we're trying to accurately determine the cells that are tall, this is not going to do it. So back to the drawing board again. So what we decided is we're going to go to machine learning. And machine learning on H&E, which is going to give us a very rich array of nuclear features, colloid, which will help us complete the cells. The black here are hand-annotated tall cells, where the yellow are hand-annotated not tall cells. And basically, it's a process. This is a process. So, and the process takes place with many people. So I couldn't do this work without Scott. I'd like to think Scott couldn't do the work without me. And it's a great team. Okay, any questions?